Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about a condition called Legg Calve Perthes disease. Also, sometimes it's called Legg Calve Perthes disease. I've also heard Legg Calve Perthes disease. This is basically named after the three people that found it or originated and coined the term. But the main thing I want you to know here to start is that this is also referred to as idiopathic avascular necrosis. And I think this is really important to keep in mind because we talk about the pathophysiology here. It's really going to explain why we can also call it this condition. Now, just as a general overview, when we talk about the hip joint, we're talking about the acetabulum and the femoral head that actually sits within the acetabulum. And a key point that I want you to note throughout this video is that anytime a patient presents with hip pain, there's a few different things that we need to consider. And some of these we talked about in previous videos, but I just want to highlight them again here. Our differential for pediatric hip pain or knee pain is going to cover a lot of different things. The first of which is transient synovitis. And the key things to differentiate this condition is there's typically not going to be a fever and there's a recent URI. Again, not always, but typically patients will present with transient synovitis or inflammation of the synovium in the hip joint. This is typically self-resolving, but you can use anti-inflammatories. Now, when we talk about septic arthritis, this typically is going to have a fever as well as a high leukocytosis or white cell count. So that's another reason that patients might present with hip pain or joint pain. And then some of the other things we're talking about in this chapter specifically, we talked about the SCFE, which is a slipped capital femoral epiphysis, when you get kind of the sliding between the femoral head and the epiphyseal growth plate. This is typically going to be in a slightly older patient. So we think about the age being approximately 8 to 16, and the x-ray is going to show some pretty classic findings again, where the epiphysis is actually slipping. Now, when we talk about DDH, this is typically going to be in a newborn or a young patient, and you're going to get those positive Bortolani and Barlow maneuvers. So I'm putting a positive exam because the physical exam is super important for this condition. And now here we are in this video talking about Legg Calve Perthes disease or Legg Calve Perthes disease, which is going to kind of round out our pediatric hip pain differential diagnosis. So you should be able to know one or two things to differentiate these on a question stem on test day. Now, if we jump into the etiology here, it's fairly simple because this is primarily idiopathic. That is to say, we don't always know why or the reason for patients having this condition. However, we do know that it typically occurs in kind of a younger age patient, approximately 5 to 10 years old. And some of the things that increase a patient's risk include bleeding disorders. This can include things like protein S deficiency, factor V Leiden, patients with genetic mutations, particularly patients who have collagen defects, and patients who are exposed to repetitive trauma. So athletes, right? Think about patients who play in sports that can get repetitively hit in the same area over and over again. Now, when we think about the pathophysiology, this will explain to us why this can also be called idiopathic avascular necrosis of the femoral head, because it's due to inadequate blood supply to the femoral head, leads to avascular necrosis or bony death and bony collapse. So let's unpack that a little bit. Recall that everything in our body needs blood supply, including the femur. So we typically have blood vessels providing blood to the femur, right? The oxygenation, the nutrients that we need. But if the blood flow is disrupted, what's going to happen to that bone? It's going to die off, right? It's not getting the nutrients that it needs. So if it has fewer and fewer and fewer and fewer vascular structures, ultimately the nice femoral head that was kind of a good circle will now be poorly perfused and can kind of become flattened, right? It can kind of become half of a circle. It becomes squished. The bone up here actually dies off. You get compressive forces from the biomechanical nature of the body, and that can actually squish the femoral head. So now we might have something that looks like this, right? This does not look nice and round and full like we used to have. It's kind of squished because the avascular necrosis lead to bony collapse. How is this going to present? Well, classically, patients will have an antalgic gait, also known as a limping gait, and they may present with hip and or knee pain. Again, a general principle I want you to keep in mind is that if a patient presents with knee pain, you should also be looking at their hip. Vice versa is also true. If a patient presents with hip pain, you should also be looking at their knees, right? There's compensatory mechanisms in the body that can cause one joint pain to actually be due to another joint. So it's kind of a general principle to keep in mind during your physical exam. Additionally, these patients can have decreased range of motion, specifically with abduction and internal rotation. So recall if we're at midline here, right? And we have a foot and a leg over here and a foot and a leg over here. Which way is abduction or abduction going to be? It's going to be away from midline versus adduction would actually be going towards the midline. Again, you're adding things together. That's how I remember those. And which way would internal rotation be? It'd be going inwards, right? Versus external rotation is going to be rotating outwards. This gets a little bit confusing when you're actually doing a hip exam. If you have the hip at 90 degrees, you'd actually be pulling the foot laterally, which would then turn the hip inwards. But the key point here is that you need to know that abduction or abduction and internal rotation are the primary things that are going to be limited in this condition because we don't have good rotation. We don't have that good ball and socket joint that we're used to having that can move all over the place. Things are disrupted, right? So it's not moving quite as well. Now, these patients can also present with a leg length discrepancy. I think this one is pretty easy to remember and pretty self-explanatory. If we have bony collapse, which we talked about right here, this can obviously cause one leg to present shorter than the other. Now, when we think about the diagnostics here, important that you get imaging for these patients. Imaging is going to show increased femoral head lucency with a flattened epiphysis. Remember, epiphysis is that growth plate, the epiphyseal growth plate, and we can see that pretty clearly if we draw our attention to our images over here, which I'm highlighting in blue, so we can take a closer look. Now, briefly, where are we? We have the sacrum up here, we have the pelvis over here, we have the femur over here. And so this right here is the femoral head. Now, look at the femoral head over here. It is not a nice, round, circular structure that would be moving around in the joint, right? It very much appears flattened. And there's this hyperlucency, or this area of whiteness, which is reflected by the flattening of the femur. So again, instead of that nice circular component, we're seeing something that looks more like this, a flattened epiphysis and a flattened femoral head. And this explains a lot of our physical exam findings, why the joint doesn't move around quite as well, because it's not really that ball and socket joint anymore. Now, there's a couple of key things I want you to know, that often the initial radiograph can be normal, right? If this is coming as an early presentation, you may not see these findings until later on. Additionally, you may consider getting an MRI if the x-ray is unremarkable. If you really suspect this condition in a child, you don't want to miss it, right? You need to do something about it typically. If the x-ray doesn't show what you think it should show, but you still have high clinical suspicion, it would be reasonable to get a better test or a more clear image with the MRI. Now, when we think about the management here, we can do things with conservative management. These include things like decreasing weight-bearing activities. Why? Because this is going to make the problem worse if you put more weight on the joint that's already being smashed. Casting, and physical therapy. There are some guidelines here that are a bit beyond the scope of the exam, but if a patient is very young, you might use conservative managements. If the femoral head is not too squished or it's not too bad a shape, you might use some conservative management because the body has a remarkable ability to heal itself. However, if there's more extensive damage or a child is a little bit older, you're likely going to need surgical intervention with a femoral osteotomy, and these patients are also likely to have a total hip arthroplasty in adulthood. Again, you can imagine these patients that are higher risk of osteoarthritis because they have a damaged hip in childhood, likely going to have more damage to their hip in adulthood. So just a quick summary to wrap up this video. We're talking about Legg-Calve-Perthes disease, Legg-Calve-Perthes disease, whatever you want to call it. This is also called idiopathic avascular necrosis of the femoral head. Etiology is primarily idiopathic, but keep in mind this age range. Why? Because we talk about other conditions like a SCFE where patients are typically a little bit older, not always, there is some overlap, or things like developmental dysplasia of the hip where patients are typically even younger. This is a very key clue that they will give you in the question stem. Pathophysiology here, really simple, inadequate blood supply to the femoral head, not getting the oxygen nutrients it needs, avascular necrosis, and bony collapse. Presentation here, antalgic gait, hip and or knee pain, either one needs to be worked up for this condition. Patients can also present with decreased range of motion and a leg length discrepancy. Why? Because of the bony collapse. Imaging here. Typically, you're going to start with radiographs, although they can often be normal, which means you might need to get further imaging with an MRI. However, those radiographs that do show something are going to often show an increased femoral head lucency with a flattened epiphysis. Why? Because bony collapse again. When it comes to the management here, we can treat this conservatively or with surgical intervention. It really kind of depends on the patient's age and how much actual damage, how much destruction has been done to the joint itself. So that's going to vary a little bit. There's kind of some intricacies there, but it's important to know that either one could be possible depending on the clinical situation. So how might they ask you something about this in a question stem? They could give you something along the lines of, an 8-year-old patient presents to the pediatrician with a limping gait after football practice. The patient's parents report he has been pretty healthy, but there's been a viral infection going around school that he had last week. On physical exam, the patient has a bruise around the left knee, along with pain around the knee and upper thigh. The patient has limited and painful internal rotation of the left hip relative to the right hip. Radiographs of the left knee show mild soft tissue swelling, but no fractures or dislocations. A radiograph of the left hip shows widening of the joint space and increased femoral head lucency. You send a referral to orthopedic surgery and should advise the patient to do which of the following in the meantime. They can give you a lot of different options here, right? They can talk about pain management. They could talk about returning to activity. They could give you a variety of different options. But the key here is determining what does this patient most likely have. They said the patient was recently sick a week ago, so they potentially could have transient synovitis, although this is less likely given the x-ray imaging showing joint space widening and femoral head lucency. This is very classic presentation or classic finding for Legg-Calve-Perthes disease. They're also distracting you talking about the knee pain. Again, knee pain or hip pain should be kind of worked up together. You need to look at both of them. And although this patient has a bruise around their left knee, probably from the football, one of the notable findings on physical exam is the limited and painful left hip internal rotation. So again, this needs further workup. The main giveaway in this question stem was certainly the imaging, but there's a lot of different things on our differential that we need to consider. So the best thing for this patient to do in the meantime before seeing the orthopedic surgeon is going to be to decrease weight-bearing activities.